So today I'll be sharing a quick contraceptive update followed by the focus of my presentation, which is going to be IUD removals and some complex referrals. So there are some slides throughout the presentation that are for reference only, so please don't worry if I whiz through them. You will be able to view them later, and I think Natalie is going to send out the presentation. Okay. So throughout the presentation, you might hear me use these abbreviations. I'll leave them on the screen just briefly so you can read them. So what's new in 2024? Well, the Faculty of Sexual and Reproductive Health have launched their new website, making it more accessible to the public. So what I like about the For the Public pages is their approach, what's right for me. So contraception, as you know, is very personal, and what suits one user might not suit another. So if you're short on time in clinics, which I know you all are, you can direct patients to this site. They can have a look at their options and then call us if they have any questions or need any further contraceptive advice. So that's our number there. So next we've got DRSP. This is the new POP in town. It's a progesterone-only pill that is taken in a continuous cycle of 24 active pills, followed by 4 inactive pills, allowing for a 4-day hormone-free interval. Each active pill contains 4 milligrams of DRSP, and an active pill can be taken up to 24 hours after the scheduled pill taking time without loss of contraceptive effectiveness. DRSP acts primarily to suppress ovulation with additional contraceptive effects on cervical mucus and the endometrium. Studies indicate that DRSP is as effective for contraception as well, and as we know, if used perfectly, POPs may be more than 99% effective. DRSP should be started on day 1 of the natural menstrual cycle for immediate contraceptive effect. If quick starting at any other time, additional contraception is required for 7 days. UK MEC recommendations for POP apply to DRSP, but please note that there are additional considerations for DRSP use, including caution in users at risk of hyperkalemia. For further information, please see the FRSH CEU statement. Okay, so the next news has been an absolute godsend to lots of LNG-IUD users throughout the country. So the FSRH now supports the use of any 52 milligram LNG-IUD for contraception for up to 8 years. This includes Mirena, Levocert and Benelixir. Any of these inserted after the age of 45 can be used, Any of these inserted under the age of 45 can be used for 8 years for contraception. Any inserted over the age of 45 can be used for contraception until the age of 55. There has been no change to existing guidelines regarding the use of 52 milligram LNG-IUD for heavy menstrual bleeding, which is still 5 years, and the FSRH still supports the use of any 52 milligram LNG-IUD for endometrial protection as part of HRT for 5 years. There has been no changes to the licenses for Kylena or JDES. So some important news, following a safety review, topiramate, which can be used for the treatment of epilepsy and migraines, is now contraindicated in pregnancy. Topiramate also has enzyme-inducing activity, and as we know, enzyme inducers can reduce contraceptive efficacy. So contraceptive options recommended by the FSRH are the copper IUD, the LNG-IUD or Depo-Provera plus condoms. The second safety notice refers to DMPA. In relation to contraception, we know it as Depo-Provera and Cyanopress. The FSRH states that DMPA should be discontinued if a meningioma, which is a type of brain tumour, is diagnosed. They also advise caution when recommended DMPA to patients with a history of meningioma. And finally, some breaking news. So this has just come out recently. The FSRH has just released a statement in response to inquiries regarding GLP-1 agonists, which you might know as the weight loss injection. So evidence suggests that Mounjaro, the weight loss injection, appears to reduce the absorption of oral contraceptives. So the FRSH advises that those who are overweight or obese and taking it should either use a non-oral contraceptive method, for example, LARC methods, combined hormonal vaginal ring or patch, or if using oral contraception, add a barrier method for 4 weeks after starting it and for 4 weeks after each dose increase. The impact of semaglutide, which I've really struggled to pronounce, on oral contraceptive absorption does not appear to be clinically significant. Diarrhea and vomiting are, however, potential side effects of both drugs, which could affect exposure to contraceptive hormones through reduced absorption. So see the FSRH statement for more information. Okay, so on to IUD removals. There tend to be 4 main reasons for IUD removals. Users may want to conceive, they might have problems or concerns, their IUD is expired or contraception is no longer needed. It's important to be familiar with the types of IUDs available if you're going to remove them. So get to know how they work, how effective they are for contraception, possible side effects, and how long they can be used for contraception. Sharing this information with the user might affect the outcome of the consultation. The most common IUDs I remove are T-Safe, which T-Safe and NeoSafe. So T-Safe is licensed for 10 years for contraception and NeoSafe is 5. Users may not know which type of IUD they have, but if they tell you they have a gynae fix, or a multi-load, then refer them to us for removal. For obvious reasons, these IUDs may cause more discomfort to the patient on removal, and you may feel more resistant when removing them. Okay, so this is a reference slide. I haven't got time to go through how the IUD works, but you will be able to look at all of this at a later date. The most common LNG-IUD, so hormonal IUD that I remove in clinic, are the Mirena and Kyleena coils. But as I mentioned earlier, there are other hormonal coils out there. For contraception, Mirena is licensed for 8 years, Jades for 3, and Kyleena for 5. Again, this slide is for your reference. With both the copper IUD and hormonal IUD, there is no delay in return to fertility. Users should be informed of this and advised to avoid unprotected sex during the 7 days prior to IUC removal. Where possible, encourage users to change method prior to IUC removal. If users have already changed methods, ensure IUD removal is timed correctly to avoid unintended pregnancy. For example, the depot injection, the implant, and the combined hormonal contraception, any combined hormonal contraception, will only provide contraceptive cover after 7 days of use. So check when they've commenced their new method. If they've only just started it, a fail-safe rule is to retain the IUD for 7 days after their last unprotected sexual intercourse. This allows 7 days for their new method to provide contraceptive cover, and that applies to both coils. You can also refer to the FRSH switching contraception guidelines, which is what I've put up, but that's just for the IUD, for more information. So prior to the consultation, for the IUD removal, you'll need lubricant, a speculum, and a sponge holder. I try to have some cotton wool around, a NAT test for chlamydia and gonorrhea, charcoal swab, and a pregnancy test handy just in case it's needed during the consultation. Prior to the consultation, follow your normal good practice. Just check the notes, be aware of age, when the coil was fitted, recent consultations relating to their coil and their medical history. Identify vulnerable groups. It's good to slow things down if you're seeing a vulnerable patient. Consider ongoing contraception and the need to involve other professionals prior to removing their IUD. So taking a thorough history can really affect the contraceptive advice you give and the outcome of your consultation. So I've just included a few things on that slide that I like to ask. Okay. So I've also included a quick reference slide about the timings of IUD removals, and I'll cover this in more detail throughout the presentation. So for your first IUD removal, I would recommend working alongside a clinician who is experienced in IUD removals. It's always good to watch one and then do one. One of the biggest risks when removing a coil is pregnancy. So, as I mentioned earlier, if they've had any unprotected sex during the last 7 days, they could conceive from that risk. So, do they need contraception going forward? Have they commenced that new method? And when did they last have any unprotected sex? If there is no risk of pregnancy and you have no concerns, you can remove their coil. Explain the procedure to the user, which I'll explain in a minute. Reassure the user that the procedure will only take a few minutes and is often less painful than the IUD fitting, which is what most people worry about. Explain that they will experience some cramping or mild lower abdominal pain whilst the coil is being removed, but that this is often short-lived. And explain that they may experience some spotting or some light bleeding following the removal, and this is normal. Reassure them that they are in control, and if they want to stop or pause the procedure at any point, let them know. Offer a chaperone, obviously, gain consent, which we all do, and recheck you have consent if the patient has any concerns during the procedure. Be clear about what the user needs to do to get ready. So people find it more embarrassing. You'll probably find this if you do smears. If they don't know what to do, they get embarrassed if they get it wrong. So I am just very open and clear about what I need them to do. Maintain dignity, which I know you all do anyway. And last but not least, small talk, and lots of it if they're nervous. So I'm going to talk you through the procedure and then I'll play a few videos. To remove the IUD, insert the speculum, visualize the cervix, grasp the threads with the sponge holders, ask the user to cough. I usually say cough on the count of 3, and then apply light tension to the IUD threads as they're coughing, and then gently remove the IUD whilst they're coughing. And then obviously remove the speculum. Coughing helps to distract the user, but if you prefer, you can ask them to wriggle their toes or just do something that distracts them. Check the IUD is complete when it's removed and make sure none of the IUD is left behind. That's very rarely happened to me. Check the user feels well following the procedure, and just bear in mind that most of the time patients are absolutely fine after an IUD removal. Occasionally some people can feel faint, but it's really not common. Offer tissues and a sanitary towel. Okay, so I've got 2 videos. They're very short, so I'm going to play them twice. They're the best I could find, so I'm really sorry about the quality of them. Okay, so just watch that one again. So as you can see, it's really easy. You just insert the speculum, grasp the threads, and then gently pull on the threads. Okay, so because it's so easy, DIY removals are trending on TikTok. The above videos have between 27,000 and 1.5 million likes each. So if they're so easy to remove, then why do we recommend IUD removal by a trained clinician? Well, it is supported by the Faculty of Sexual and Reproductive Health. It also ensures that removal is correctly timed to avoid unintended pregnancy. It minimises risk of complications such as failed or incomplete removal, trauma, pain, and infection, and it also allows the device to be checked. So, on to the case studies. These case studies have obviously been influenced by my practice, but the scenarios and people aren't real. So, I've been, as you'll notice, there's a bit of a theme of flowers. So, enjoy. Okay, so Blossom is 30 years old. She had a Mirena fitted 3 years ago. She's attending for Mirena removal and she's wanting to conceive. She's had no previous pregnancies. So what did I do? Well, I informed her that fertility would return immediately. Her last sex was 2 days ago and was unprotected. I made sure that she was aware that she could get pregnant from any unprotected sex that had occurred during the last 7 days, and she was happy to conceive straight away. Blossom didn't have any medical problems. She wasn't taking any medication and had no allergies. But it is good to remember that some women may need to plan pregnancy. If they have complex medical or mental health conditions, they may want to discuss their plans with their GP or consultant prior to stopping contraception. I also advise women to check that any medication they're taking is safe to continue during pregnancy. So it's also good to check women are up to date with cervical screening. If they're due a smear test or they're overdue, they might want to just keep their IUD in until the results of the smear test is known. So what did I do? I removed a coil. I gave her some preconceptual advice. So I advised her to start taking folic acid, 400 micrograms daily. And as we've heard earlier, some individuals may need a higher dose of that, and you just take it through the first 12 weeks of pregnancy. I encouraged her to stop smoking and not to drink alcohol if pregnant, and she felt able to stop smoking without support. Okay, so the next case is she's Poppy. She's 23 years old. She had a Kyleena fitted 1 month ago and she's pregnant and not wanting to continue with the pregnancy. She's amenorrheic with the Kyleena and she doesn't have any lower abdominal pain. So pregnant and needing coil removal isn't something we see often at all. So I don't want you to be worried, but I thought it would be helpful as a scenario just in case you ever encounter it. So what would you do next? So Poppy hadn't really been honest about a contraception prior to having the Kyleena fitted. She informed me she'd taken oral emergency contraception in her previous cycle and that her last period was much lighter and shorter than normal. She'd also had other sex prior to having the coil fitted that was unprotected and unprotected sex during the 7 days after. So my next steps were to confirm the pregnancy. So I asked Poppy to do a pregnancy test in clinic. The pregnancy test was positive. So what now? So the guidance, the FRSH guidance says risk of pregnancy during use of IUC is lower than when using no contraception. However, if pregnancy occurs with IUC in situ, the likelihood of it being ectopic is greater than if a pregnancy was to occur without an IUC in situ. So we needed to exclude ectopic pregnancy. So symptoms generally appear at 6 to 8 weeks after last menstrual period. Poppy didn't have any symptoms of ectopic pregnancy. So what did I do? I did Poppy's observations. Her blood pressure, heart rate, and temperature were all within normal limits. Poppy was not in any pain and she looked well, so I referred her to the early pregnancy assessment unit and she was seen 2 hours later, where they did an ultrasound scan. If your patient is hemodynamically unstable, so pale, tachycardic, hypertensive, or appears to be in shock or has collapsed, hopefully not, or if you have any concerns about the degree of bleeding or pain, you should speak to a senior clinician or doctor as they'll need urgent medical attention. Obviously, if there's no doctor on site or they have collapsed or are really unwell, phone an ambulance. So Rose, she's 23 years old. She had a NeoSafe fitted 9 weeks ago. She's been experiencing some symptoms of intermenstrual bleeding, lower abdominal pain, pain during sex, and increased vaginal discharge. She'd like to have her IUD removed. Her last period was 2 weeks ago. She has a casual male partner of 4 weeks. A swab for chlamydia and gonorrhea was done prior to having her IUD fitted, and both were negative. So her last sex was 2 days ago and it was unprotected, and she's had other sex during the last 3 weeks. So taking a thorough clinical history is really important. So I've just left that slide for you, and it helps you in the management of your patient. I had to consider possible causes of Rose's pain. So could her pain be caused by malposition of the IUD, partial expulsion, perforation, pregnancy, PID, or an ovarian cyst? It's also worth considering non-gynecological causes of pain. In Rose's case, we also need to consider pelvic inflammatory disease. Her STI risk is high because of her age, the type of relationship she's in, and the fact she's had one new partner since the IUD was fitted and since her last STI screen. It is important to remember, though, that PID isn't always caused by an STI and that other bacterial infections can play a role. So individuals with symptoms of PID should be assessed by a trained clinician. Those with suspected PID should be given antibiotic treatment and managed in accordance with BASH guidance and reviewed 48 to 72 hours afterwards. If you suspect an STI is the cause of PID or symptoms of it, refer the patient to Sexual Health Sheffield. You'll need to speak to the duty doctor and they will be able to book the patient onto their symptomatic clinic if they're concerned. If you feel the PID is unrelated to an STI, discuss with a doctor in your team. If there are no doctors available, obviously there is gynae on call, but I think that would be if you didn't have anyone else you could talk to. So on commencing antibiotics, those individuals with mild to moderate PID whose clinical condition is improving can actually retain their IUD. So when users have pain with an IUD, they often worry that it's caused by uterine perforation. If they mention perforation, please explain that it's rare and that the overall risk is 1 to 2 per 1,000 people. Reassure them that you'll try to exclude perforation, and that so the signs of that are lower abdominal pain, non-visible threads, and changes to bleeding. But it is good to note that IUD threads can curl up inside the cervical canal and can often be pulled down with a thread retriever, and then the IUD is just removed as normal. This is definitely more common a cause of non-visible threads rather than perforation. With any signs of perforation, an ultrasound scan should be arranged as soon as possible. Advise them to use additional precautions until the position of the IUD is confirmed. If you have any concerns regarding the severity of pain, then refer them to a doctor for further assessment. Okay, so back to Rose. Just a reminder, she's got intermenstrual bleeding, lower abdominal pain, and pain during sex. So what happened next? So I did observations, again, all within normal limits. Rose did a pregnancy test and a low vaginal swab for chlamydia and gonorrhea. Pregnancy test was negative. I did a speculum examination and there was no vaginal discharge or signs of infection. Did a high vaginal swab and sent that off for culture and sensitivity. Her cervix looked healthy, but then as I looked closer, I could see that the stem of the IUD was in her cervical os, so her coil was half in and half out. I explained to Rose that her IUD had partially expelled and that she needed it removing. So expulsion happens to about 1 in 20 women, and it's more common during the first 3 months. Rose had unprotected sex 2 days ago, so I explained that there would be a risk of pregnancy if I removed her coil today. Rose wanted me to remove her IUD, so I did, and she accepted emergency contraception. With patients experiencing partial expulsion, their pain tends to decrease significantly when you remove their IUD, which is what happened with Rose. She felt her symptoms improve very quickly. So I explained that I couldn't exclude an STI, but would refer her test results and, sorry, not refer, review her test results and contact her if there were any positive results. So the partial expulsion explained a lot of her symptoms, but it is important to safety net patients in this situation. So I advised her to seek medical advice if her symptoms worsened or persisted. I phoned her on the day after to follow up, and her symptoms had completely resolved. Okay, that's just another reference slide for you for expulsion. So we've still got a bit of time, haven't we? Jasmine is 45 years old. She had a Mirena fitted 5 years ago. She would like it to be removed because her partner's had a vasectomy. She was very happy with her Mirena coil and had not had any problems during the time that she'd been using it. So what happened next? On speculum examination, her cervix appeared normal, but the IUD threads were not visible. I informed her of the same, so we had a bit of a chat about that. So with patients, I try not to use the phrase missing threads because it alarms them and they don't understand it. So we use the term non-visible threads. So she didn't need a pregnancy test because her partner had had a vasectomy and it had been a success. If the user is using the IUC for contraception and the threads are non-visible, you do need to exclude pregnancy and consider the need for emergency contraception. If you are giving them contraception, you just need to be aware that ulipristal acetate, so UPA, interacts with progestogen. So if they've had a Mirena coil in and the threads are missing and you give them UPA, then the UPA is less effective. So, and that's if they've used progestrogens during the 7 days prior to taking the UPA, so ulipristal, which is also known as Ellawan, if you've heard of that. So so what I did was advised so sorry, I'm losing my thread there. So if they have had if they're needing contraception, you also need to advise them to abstain from sex or offer them alternative contraception until the position of the IUD has been confirmed. So what did I do? Well, I referred Jasmine to Sexual Health Sheffield's complex contraceptive clinic and wrote to her GP to request that she be referred for a pelvic ultrasound scan to check the placement of her coil. You can access the referral form for complex contraception via the e-referral service. I think that's how you guys do it. We do it a bit differently because it's like an internal referral. Okay, so it's not very clear that, but that's thread problems reference. Okay, so we got time for one more. I think we might. So Daisy is 22 years old. She had a Mirena fitted 12 months ago and she's experiencing intermittent lower abdominal pain, postcoital bleeding, and pain during sex, all since the Mirena was fitted 12 months ago. She has no other symptoms. She's amenorrheic with the coil and she has a regular partner of 2 months. Her last STI screen was 2 weeks ago, and chlamydia and gonorrhea were both negative on that swab. Her last sex was 7 days ago. So what happened next? So I did a pregnancy test and Daisy did a low vaginal swab. The pregnancy test was negative. On speculum examination, a cervix appeared normal. The IUD threads were seen in the cervical os. There wasn't any signs of expulsion, so no signs of the stem of the IUD. I attempted to remove the IUD and felt resistance. So she was experiencing some mild cramping, and I asked if she was happy for me to try again, and I did. I applied slightly more tension and felt some real resistance, and Daisy had some lower abdominal pain. So I abandoned the procedure. I referred Daisy to the complex contraceptive clinic. So I explained that contraceptive cover could not be guaranteed and that she should use alternative contraception until the placement of the IUD is known, and consider the need for emergency contraception if there'd been any recent unprotected sex, which there hadn't with Daisy. I safety netted her and just said, if your symptoms worsen, get back in touch or seek medical advice. Okay. In the meantime, I reviewed her swab results and they were normal. So, Emma, what do you think? Should we do a few more case
Yep,
studies? Or
you've
yeah?
got until 1:15.
Okay, so I'm
Um,
hoping no one's getting bored. Okay, so
yeah, and there's
yeah.
one question so
Okay,
far.
that's great. Okay. So William is a 28-year-old trans male. He was assigned female at birth, but now identifies as male. He had a Mirena fitted because he needed contraception, but also hoped his menstrual bleeding would stop altogether. He has a regular male partner of 6 months. So he's been experiencing prolonged spotting and frequent bleeding since the Mirena was fitted 2 months ago, and once it removed. So, what bleedings can we expect after LNG-IUD removal? Well, for LNG-IUD users, altered bleeding patterns are common. During the first few months after insertion, the number of bleeding and spotting days should decrease with time, and users can see a 90% reduction in menstrual blood loss during the first year of use. At 1 year, infrequent bleeding is common, and some users are amenorrheic. I think it tends to be more than that, but that's what the research shows. So I was glad that William was up to date with his cervical screening and that his last smear was negative. I did a pregnancy test, and this was also negative. William did a self swab for chlamydia and gonorrhea. I did a speculum examination, his cervix appeared normal, and the IUD threads were visible. There were no signs of expulsion or infection and no pain on speculum examination. So I reassured William that the bleeding he was experiencing appeared to be an expected side effect of the Mirena coil. William had no medical problems and was not taking any other medication and had no contraindications to combined oral contraception. So I recommended a 3-month trial of COC for bleeding control. William decided to keep his Mirena coil and wanted to do the trial of COC to see if it settled the bleeding. I advised him to seek medical advice if his bleeding didn't improve or if he began with any new symptoms. So it's just important as well to be aware that transgender individuals experience varying levels of dysphoria with their anatomy, which you can imagine, and genital examination during IUC removal can cause additional physical and emotional discomfort. So that's just about bleeding patterns. All of this can be found on the FSRH website. It's really a great website to get access to. So should we do one more? I think this one's a quick one. So Violet is 51 years old. She had a Mirena fitted 5 years ago. Her card states that her Mirena coil's expired, so she would like it removed. She's not using HRT and hasn't really had any symptoms of the menopause. Lucky thing. So she's in a relationship and needing contraception. Her Mirena was originally fitted for contraception and for treatment of heavy menstrual bleeding. Violet is amenorrheic with the Mirena. So, what do you think happened? Well, she kept her Mirena coil. As we know, FRSH guidance states that any 52 milligram LNG IUD inserted over the age of 45 can be used for contraception until the age of 55, where loss of fertility is assumed for most women. It's good to remember that some users will not be aware of the new license for Mirena. So if they are under the age of 45 and their card states their Mirena expires at 5 years, please reassure them that they can continue with their Mirena for contraception for up to 8 years. Violet is not using HRT, so she doesn't need her Mirena changed for at 5 years for endometrial protection. However, she did have it fitted to treat heavy menstrual bleeding. And the manufacturers of the Mirena recommend that if symptoms of heavy menstrual bleeding have not returned after 5 years, continued use of the system may be considered. So Violet was happy to keep her Mirena coil. So that one's quite self-explanatory, so you can all have a look at that. I want to give you time for questions if you need it. Okay. Has anyone got any questions? Let me have a look.
So Heather Moorhouse has asked, do we need any formal training to remove coils? I think you kind of covered it, but
Yeah,
I don't believe there are any courses or things you need to do.
no, I think it's just being aware of things like pregnancy risk, ongoing contraception. I would recommend for your first removal to be with a clinician who is confident in removing coils. Watch them do one, and then they'll watch you do one. And if you've got any questions, you can ask. But then after that, it's just you will get a feel for the amount of tension to apply. But, if women are taking them out at home, I think as long as you're familiar with FRSH guidance, um, you will be fine to remove them.
Yeah, it's quite scary, that TikTok trend,
And
isn't it?
yeah, I couldn't believe it. There was over 50 videos.
Blimey. Um, any other questions?
No. Hope everyone's not scared.
And just to confirm, we are sharing the slides, aren't we?
Yeah, we are definitely. Yeah. Yeah.
Brilliant. Yeah, because there's loads of information on there. I
Yeah.
haven't,
There was just so much to cover, and it would have taken me hours to read it all.
yeah. We're getting lots of thanks. I mean, it was
Oh,
brilliant. Thank you
oh,
so
thank
much,
you.
Gemma.
Yeah, I've
It was
enjoyed
really
doing
good.
it.
Yeah, I learned loads and I'll want a copy of the slides as well. Um, right, if there aren't any questions, shall I move on to my
Yeah,
bits?
please do.
Yeah,